The commission meeting will now come to order. Commissioners, included in your packets are the copies of the minutes from our previous meeting on June 21st, the public meeting of the commission. You've had an opportunity to read the minutes, absorb the minutes. I would like to entertain a motion to approve the minutes of the June 21st meeting. I have a motion. Second. All in favor? Any opposed? Okay, very well. Commissioners, you have received written updates from all of our centers. You've had an opportunity to read them, absorb them. Do any of the commissioners have any questions on the written updates at all?
I did.
Commissioner Sargent.
On the CRISP audit reports, the draft ones, do we have any idea when those will be finalized and made public?
Good afternoon, David.
Good afternoon, Mr. Chairman, Commissioners. Commissioner Sargent, the question I understand is when the financial audits are produced for the CRISP for this particular year. We're looking at probably September, October of the completion of them. So we can anticipate safely an October release.
And does that include there's also draft privacy and security audit reports?
The privacy and security audit reports around the same time frame we're aiming for.
Thank you. Commissioners, any other questions? Very good. Mr. Executive Director, do you have any updates?
So I wanted to just inform the audience that we got started late today because we had an educational discussion on the new total cost of care model. We reviewed the document that was signed by Governor Hogan and Adam Bowler of CMMI last Monday, and we look forward to working with our colleagues across the way in implementing that very ambitious model. I also wanted to announce that I have named Bridget Zumbro, our Chief Administrative Director, Chief Operating Officer for the Commission. She serves roles that are consistent with a COO, and it's appropriate that she have that title. I think Bridget was there a minute ago, but I think as she is doing often, she's back operating as we would want her to do. So I think it's a well-deserved recognition of her importance to the Commission.
Thank you very, very much. Teresa, do you have an update?
Thank you. Good afternoon, Mr. Chair, Commissioners. I am very pleased to introduce our newest member of the Quality Center team, Stacey Howell. Stacey, stand up. Thank you.
Very good. Welcome, Stacey.
Stacey will serve as the Chief for Long-Term Care and Health Plan Quality. Prior to coming to the Commission, Stacey worked as a research associate with the University of Maryland School of Medicine and as a health policy analyst for CMS. Stacey holds a PhD in developmental psychology from the University of Maryland and a master's degree in psychology also from the University of Maryland. A major focus for our center in fiscal year 2019 is to enhance and redesign our long-term care guides. Stacey will lead that effort, and in fact, she's begun by working with our contractor that performs our experience of care family survey for nursing homes. So if you would join me in welcoming Stacey.
Thank you very much. That's great. Congratulations. Okay. Eileen Fleck, I understand you have an update, Eileen, on the status of the cardiac services proposed regulation.
I do, but I actually also wanted to introduce a new member in the division, Mario Ramsey, if you could stand.
Very good.
So Mario Ramsey is a native South Carolinian who has worked in various roles in health policy. He served as a healthcare analyst with the U.S. Government Accountability Office, a fellow with the Center for Medicare Advocacy, and a fellow with the Satcher Health Leadership Institute. He joins us from the Centers for Disease Control, where he most recently served as a policy fellow in the Office of the Director for the Division of Public Health Information Dissemination, which produces flagship CDC publications such as the Morbidity and Mortality Weekly Report and Vital Signs. This office also supports the Community Preventative Services Task Force. He holds a Bachelor's of Science from Clemson University, a Master's of Public Health from the Morehouse School of Medicine and a Juris Doctorate from Wake Forest University. He is also licensed to practice law in the state of Maryland. So please join me in welcoming him.
Congratulations. That's wonderful. Eileen, you do have another matter, right?
Yes.
Okay. Just want to make sure I got it right.
So I'd like to briefly update you on the review of certificates of ongoing performance applications and the regulations for cardiac surgery and PCI services. As MHCC staff moves closer to completing the review of the first batch of applications for cardiac surgery programs for a certificate of ongoing performance in May of this year, a collaborative organization for the Maryland cardiac surgery programs raised concerns about the use of one of the performance standards. This standard provides that a hospital with an all-cause 30-day risk-adjusted mortality rate for a specific type of cardiac surgery cases, such as coronary artery bypass graft cases, that exceeds the statewide average beyond the acceptable margin of error for the hospital by the Commission is subject to a focused review. So as staff has explained previously, the use of risk-adjusted mortality rates for hospitals compared to a statewide benchmark was endorsed by the Commission's Clinical Advisory Group, which was formed at the direction of the legislature for the specific purpose of making recommendations regarding the regulation of cardiac surgery and PCI services. When feedback was solicited on draft and proposed regulations, some stakeholders proposed that a national benchmark developed by the Society of Thoracic Surgeons used instead of a statewide performance benchmark. In part, staff responded to this by noting that it was not an option because the Society of Thoracic Surgeons would not allow it. So MHCC contracted with the Society of Thoracic Surgeons to obtain calculations for the all-cause 30-day risk-adjusted mortality rates for isolated CABG for each of Maryland's 10 cardiac surgery programs and the statewide mortality rate, both because of the expertise of STS and the cost-effectiveness of choosing them. So in preparation for developing final staff reports for the certificates of ongoing performance, staff reached out to STS and its contractor, the Duke Clinical Research Institute, to ensure that we understood how the Duke Institute had developed the calculations described in MHC's regulations. The information provided by the Duke Institute raised concerns among staff regarding the validity of the information for evaluating Maryland's cardiac surgery programs, and we determined that the best alternative would be to use a national benchmark and requested that STS reconsider its position regarding the sharing of that information. STS has agreed to provide a national benchmark for use in the evaluation of applications for certificates of ongoing performance. STS may have changed its mind over the release of the national benchmark because it does prefer that we use the national benchmark as opposed to a statewide benchmark. And this change would be consistent with the approach that we're using for evaluating PCI services, which is a national benchmark developed by the American College of Cardiology. In order to use the national benchmark from STS for the evaluation of Maryland's cardiac surgery programs for the Certificate of Ongoing Performance reviews, MHCC would need to adopt revised regulations. For this reason, staff is not recommending that the Commission adopt the proposed COMAR 1024-17 regulations as final regulations at this time. We plan to ask the Commission to consider adopting new draft regulations as proposed regulations in the fall, and we would finalize staff reports for certificates of ongoing performance once the new regulations become effective.
Very good work, Eileen. Any members of the Commission have any questions? Commissioner Sargent.
And do we need like emergency or temporary regulations, or is this just something that can wait until we finalize the final one?
We can just wait until finalizing the regulations.
Director?
So to adopt emergency regulations, we would have to take those immediately to AELR. Recently, AELR, which is the Administrative Executive Legislative Review Committee, which is made up of legislators from the House and Senate, have taken a pretty narrow definition of what constitutes emergency, and as long as we could make the case that life and safety were in danger, we would have an easier case. I think based on our evidence to date, that these are important things to do, but they do not pose a risk to life and health and safety, that they might not concede that it's an emergency.
Commissioner O'Connor.
I think most hospitals have their own built-in quality assurance committee that would certainly look closely at any higher rate than average morbidity, mortality, and operative procedures. So I don't see a need for emergency type of move.
Commissioner Pollak.
So I just want to congratulate you on making that change and support it wholeheartedly. I think as Commissioner O'Grady articulated very clearly, I think about 3 months ago when we talked about this, the idea of using a state benchmark is never as robust as the state benchmarks are never as robust as the national benchmark. And particularly when you risk adjust them, the ability to get valid data from a much smaller pool is much less valid than what you get nationally. And the SPS database is extremely robust. I understand we couldn't get that information before. Now we think we can get it.
Yes, they have
makes infinite sense.
communicated that to us, and they've actually given us the information.
This is better. This is an improvement. I don't think we need to do it emergently, but thank you.
You're welcome.
Any further questions for Ms. Fleck? Thank you very much, Arlene. Very, very good. Fine work. Thank you. Our next item relates to the hospital performance on health care associated infection measures. The Commission has updated its hospital performance measures on infections and does so annually. This is the first year that our public reporting on these infections is based on updated baselines. So the Commission staff was somewhat uncertain about how Maryland would perform. Results, however, I am happy to report, are generally positive, although not directly comparable to our earlier results. Courtney Carter, Chief of Hospital Quality Performance, is going to provide an overview and a demonstration on the healthcare reports related to the healthcare associated infections. She's going to look at 3 areas: catheter-associated urinary tract infections, surgical site infections, and healthcare personnel influenza vaccination rates. Courtney, thank you very much. The floor is yours.
Thank you very much, Mr. Chair and Commissioners. So as you mentioned, we recently completed our annual reporting for healthcare-associated infections. So we're going to give you a brief overview of our requirements. We'll give you the results for calendar year 2017, and we'll also give a brief demonstration of the website and show you where you can find those results and some other functionalities of the site for our new commissioners. So healthcare-associated infections are also called HAIs for short. Those are infections that a patient acquires while they're in the hospital getting treatment for a different condition. They are largely preventable, but unfortunately still remain a common complication, not just in Maryland, but nationally. So in 2008, Maryland hospitals have been required to publicly report certain HAIs using CDC's surveillance system. It's called the National Healthcare Safety Network, or NHSN for short. So results early on were not very good. Maryland's looked pretty pitiful. But since then, we've introduced different types of infections, and we've seen a lot of improvements. So the results, or the requirements, are listed on the screen. So the first 2 I list are central line-associated bloodstream infections. Those are called CLABSIs. And catheter-associated urinary tract infections. Those are both device-associated, so a device external to the body. And we look at different locations within the hospitals. So we look at ICUs and select wards separately. And we also look at NICUs for CLABSIs. The next 2, MRSA and C. diff, those are called MDROs, or multi-drug resistant organisms. Those are some of those nasty, like, superbugs you might hear about on the news. They're really difficult to treat with certain antibiotics. And we look at surgical site infections for 5 different procedures. So colon surgery, abdominal hysterectomy, coronary artery bypass grafts, hip replacement, and knee replacement. And not quite an infection, but we also look at vaccination rates among hospital employees. So in 2014, we decided to align with the CMS requirements based on the recommendations from our HAI Advisory Committee. With one exception, we were already collecting surgical site infection data for 3 procedures for CABG, hip, and knee. So we decided to continue that, and we are still collecting that data. So you won't find national data at that for those 3 procedure types. So we do not have any changes in requirements for calendar year 2017. But as the chairman mentioned earlier, this is the first year that we're reporting using the updated baselines. So back in late 2015, CDC changed some risk adjustments to help really drive improvement. So we weren't sure how results were going to look. So our results from 2017 and forward are not directly comparable to previous years of reporting. So that's going to make trending a little bit more difficult. So how did we do? We have met or exceeded the national baseline for all of the infections that we report on. So for CLABSI, CAUTI, and C. diff, we're doing significantly better than the national baseline. For MRSA, we're performing about the same as the national baseline. But one thing I want to note about MRSA is Maryland as a whole, hospitals have been pretty stagnant, but we are seeing declines in the raw number of infections for MRSA. And this is the first year that we've had fewer infections than predicted. So I think it's a good sign of progress. And then for surgical site infections, we are performing better than the national for colon surgery and knee replacement, and about the same for hysterectomy, CABG, and hip replacement. And for the flu vaccination rates, about 97% of hospital employees in Maryland have gotten their flu shot for the 2017-2018 flu season. This is the 5th year in a row that we're at 97%. We are usually in the top 3 or 4, so we don't have the national rates yet, but I imagine we'll still be among the top performers. So just a couple of things that we're doing on our end to continue promoting improvement. We do hold quarterly HAI Advisory Committee meetings, and in the past, our advisory committee members have really helped us determine which infection types we should report on and how we should display it on our website. But this year, we've opened it up to all infection preventionists at the hospitals. It's been a really great forum for them to get together to discuss best practices, really hear what other facilities are doing, because even though one facility might be doing great in C. diff, they might have really poor quality performance. So we've gotten really positive feedback, so I do think we'll continue with those webinar events as long as it's warranted. We do want to continue promoting our website. We want consumers to know where this information is and to be able to access it and to really be informed to make decisions on their healthcare. And we continue to work with other stakeholders and provide support for some of those agencies who are doing the quality improvement activities to promote improvement. So before I go into the demo, do we have any questions about the results?
Commissioners? Yes. Commissioner Pollack.
When you report surgical site infections, can you give me the time frame?
It's 30-day readmission. Actually, it's 90-day, I'm sorry.
90 days.
Yeah.
Surgical site infections.
So CMS reports on 30-day readmission. So we publicly report on 90-day on our website. So there's 2 different models for colon and hysterectomy.
Commissioner O'Connor.
So this is just infection rates for in the readmitted?
Yeah.
What about the self-reporting by physicians for, we get forms to fill out after every colon surgery. Are you using those? Or you just...
So we're using data that is entered into NHSN by the infection preventionist.
Not every infection is readmitted to the hospital, that's what I'm saying.
Right. Any other questions?
Any further questions at all? Yes, Commissioner Boyle.
I do have one, and this will probably be a question I'll have with any discussion of websites, we talk about, trying to promote this more to users, and you've got great information. I have to say I'm new to this, and I've never heard this data existing. And I ran a national patient organization, so I'm not totally unfamiliar with medical terms, and I'll be curious over time how this is being promoted to the general public.
Yeah, so it's something that we're always focused on because we do struggle a little bit, and occasionally we do have contracts to help us with marketing and advertising. We try to give demos whenever we can to large audiences. We're always talking about it as part of our work. It is our main charge because we do have a lot of information, and we do want people to use this information. And we've learned that it's not just a one-time thing, let's talk about the website, because people forget about it, or you're in front of new audiences. So we do try to get up here occasionally to help as a refresher. And I'm sure we'll have more marketing contracts in the future. Okay, so to get to our website, you can either Google the Maryland Healthcare Quality Reports, or you can go to healthcarequality.mhcc.maryland.gov. And this will take you to our homepage. So here on the left-hand panel is just some administrative links, how to use the guide, who we are, how to contact us, just some background information. And then we have these rotating stories on the homepage, and those are just short 2 to 3 paragraphs, hot topics or things we think consumers might find interesting. So then up here at the top menu, we have our different guides sorted by setting. So the first guide is the hospital guide, and this is where you'll find infections and different quality measures and anything related to inpatient hospitals. So while we're talking about infections, I'll show you a glimpse of that data. So this takes you to our landing page with a little bit of background. And then on this right-hand panel, lists each of the infection types that we require. So you can click on whichever one you're interested in. So I'll click on surgical site infections. And then up here at the top, you can select any type of infection that you want more information on. And then for surgical site infections, you can select whichever procedure you want more information about. So I'll stay on HIP. And then this is your time period. So it's by calendar year. And information exists. So because we phased in infections at different years, not all infections will go back to 2012. So this heading information will match what you selected in this section. And if you have any questions about certain things that you might see, you can click on one of these green circles with the question mark, and that'll give you information. That'll tell you what a surgical site infection is. So if you scroll down, you can actually see the performance for each facility. And all the way at the bottom, you can see how Maryland has performed relative to the national benchmark. So if you want more specific information about a facility, you can click on this arrow to expand, and that'll give you those numbers. So AAMC had 1 infection, 876 procedures. Based on NHSN models, they were expected to have about 8 infections. So then this SIR is a metric where we measure performance. So not a lot of people are familiar with this. So if you click on this, it gives you a nice explanation of what the SIR is. You don't have to read this. Lower is better. You want it below 1 because that means you had fewer infections than expected. And then the confidence intervals tell us whether or not it was significant. So that's how we determine this hospital performance status. And this will give you more information about confidence intervals. Now, if you're looking at 2 different facilities, you can compare. So I'll just select 2 random ones, and you can do up to 5, and then you can click compare. And then it will bring up each different type of infection. But since we're looking at SSIs, this is what it expanded to. So you can compare all of the different procedure performance results by hospital, and then also the state is at the end. I'll stop if there are any questions. No? Okay. So real quickly on HAIs, also we have, for some of those infections where we look at different locations, you can select whether or not you're interested in ICUs or NICUs or select wards or the total of all of them. So right now, we're looking at Class Bs for ICUs. So we can see performance for each individual facility. So that's HAI performance results in a nutshell. And I have a couple of highlights I want to hit on the website. Oh, go ahead.
Just a quick question about that. I was looking at that and just thinking, if I look at that, it doesn't really tell me, I don't want to use the term rate, but I guess that's the one. So let's say there's 3 hospitals that it says it's the same, it's the same, it's the same. But it doesn't tell me, well, they're the same because it's already so low, like the hospital that there's only one. If somebody only has one, that's one every year, maybe as good as it ever gets. It's going to look like a hospital that's better. Maybe theirs is really bad, but their rate this year is actually still pretty bad. It's just better than last year. If I'm a lay person and not used to looking at statistics, that doesn't really, I'm not sure what picture I'm supposed to, does that make sense? Like I'm not sure what I'm supposed to get out of that view, other than they did better than last year, or the thing.
Well, so it's not better than last year. It's better compared to the national benchmark.
Okay.
So, and because we can't trend, since this is a new baseline, it is something that we want to look at in the future, being able to trend HAI data and other related information, but we can't do that yet.
Commissioner Camarcio, and then.
So, quick question. When there is not enough data, what is usually the explanation on that?
So the explanation is either there were few procedures, if it's a surgical site infection, or, so I'll show you an example. For catheter. So you'll see it everywhere. So I'll just stay on here. But if you go down to one of these examples and expand, so the number predicted here is 0.44. So anytime the number predicted is less than 1, an SIR is not calculated because it has to do with statistical precision. So they don't want to unfairly disadvantage hospitals that don't have at least one full infection. Yep, so this is how you expand.
Commissioner Boyle.
Hi. On the page hospital associated infections, you underline it's important to note that many HAIs are preventable. I clicked on that, and a wonderful chart came up that for what patients can do. So my suggestion would be that's hidden. You know, most people won't. You know what that says. It's important to note that many HAIs can be preventable. Maybe come up with some friendly language as you click here to see what patients can do or questions to ask. But it's a great chart.
Yeah, thank you for that suggestion.
Excellent suggestion. Commissioner Sargent.
Well, my suggestion won't be nearly as helpful, but the data on here is great and is absolutely essential. But I was wondering if we want folks that are not professionals to be able to use it. I don't know how we do this, but some way of conveying what it means. Now, I don't want a temporal line infection. That sounds bad, but I don't know. I don't know how, and I know what it is, but I don't know how to weigh the rate for any particular hospital versus all of the other things I should be concerned about when I'm picking hospitals, right? I don't, for example, it's like rating the door locks on your car versus all these other factors when you buy a car. Like, I don't know how much emphasis to give on those different things, even if I know what they all are in the first place.
Right.
The consumer side. I don't know how you do that, but it seems like a tough problem.
I don't think we can solve that problem really. I think we're just trying to give consumers the tools to make those decisions, especially if they're in a situation where they can choose a hospital. We want them to be able to look at everything.
Right, and that's what I was sort of encouraging, I guess, while we're putting the data up, which we must, if, to be on the lookout for approaches that we see where somebody's been able to convey the meanings of these things along with the underlying data.
Yes, that's a great suggestion.
Commissioner O'Connor.
Yeah, I just wonder what the definition of your inspection is, and do you adjust central lines for how they would put it? In other words, in a trauma situation, I would suspect the infection rate is probably higher. So do you adjust it for, is this an elective central line, is it emergency,
Yeah.
trauma?
The clinical criteria is very specific in the CDC surveillance system, so they do risk adjust for all of that information.
Very good. It's a good question. Any further questions at all? I just have a simple observation. I think, as everybody on the commission recognizes, this is a very, very fine piece of work, the collection of a lot of very valuable information. Once again, the problem here, and I think it's a problem with the commission, it's been a problem in many areas of public policy, where the quality of the research, the staff work is so fantastic, and we actually have tremendous information that would be profoundly valuable, useful to the general public, but they don't know it exists. I think that's something we're going to have to discuss further, but it's really a problem, it seems to me. For example, do members of the state legislature, and just, for the record, do members of the state legislature realize the degree to which we have actually improved our performance in this area over the past 4 years? Because that improvement has actually been pretty significant. And I know that we're working with the hospital executives. I mean, they're very well aware of it. They're very well aware of the fact that we have, allied ourselves with a leapfrog group, and they've got an independent standard too. But it's really critical, it seems to me, that the key players, state legislators, for example, should know all about this. Because frankly, it makes the commission look good. We actually do a very good public service, but once again, people have to know about it. The other item that comes to mind on this is, who is actually going to be interested in this? Well, the payers are going to be interested in this. And when it comes to the payers, I'm not talking about the insurance companies necessarily. I'm talking about the people who actually really pay the bills, which is households. In most cases, dealing with insurance, it's the employers. And I think that an outreach to employer organizations in this area would be very useful. Because they're looking more and more to secure, the language today, the fashionable phrase is they're looking for value for their dollars. Well, this is one area where we can actually help them achieve that. And so I would just very strongly, I know that I know that Megan has been working on this and the staff is very well aware on this, but the point is it's really critical, I think, for the commission to do what it can to spread the good word when the word is to be spread. And we've done, I frankly think, Maryland has made some really positive strides in the past few years, and we ought to at least let our legislators know about it. Thank you very, very much, Courtney. Excellent. Okay, ladies and gentlemen, the next item is an application for a certificate of need. The Visiting Nurse Association of Maryland applied for a certificate of need to expand its services on the eastern shore of Maryland. They want to provide home health agency services to the residents of Dorchester County. Bill Chan, health policy analyst, is going to present staff recommendations. Bill, good to see you.
Good to see you too, sir.
Take it
you,
away.
Chairman Moffett and Commissioners. The project before you is Visiting Nurse Association of Maryland, which is the largest home health agency in Maryland, presently serving 18 jurisdictions. It recently expanded its services to the Upper Eastern Shore with a CON approval in July 2017. The Commission established a home health agency project review cycle in 2017 for the 4 counties in the Lower Eastern Shore, which include Dorchester, Somerset, Wycomico, and Worcester. Based on the 2016 update of the State Health Plan, these jurisdictions were identified as having highly concentrated home health service markets. Our objective in establishing this review cycle was to get new entrants to the market and create a more competitive balance in the region with more choices for consumers. VNA of Maryland was the only entrant in this review cycle. In accordance with state health plan standards, VNA qualifies for docketing of an application based on its good level of performance with respect to the Centers for Medicare and Medicaid Services Home Health Compare quality rating. VNA originally proposed expanding its services to the entire 4-county region, but amended this application to limit expansion into Dorchester County after Peninsula Home Care opposed the project and sought interested party status. Peninsula Home Care does not serve Dorchester County, but does serve the other 3 jurisdictions in the lower shore, and withdrew its opposition after this change in the C1 application. Based on MHCC's survey data, Dorchester County has seen substantial recent growth in the demand for home health agency services. The total home health care visits nearly doubling between 2010 through 2016. Additionally, like the trend in Maryland, the elderly population that is the chief consumer of home health services is growing rapidly, with projected growth of just under 50% in the 65 and elderly population between 2015 and 2030. While there are 6 agencies authorized to serve adult patients and 1 agency specialized in serving pediatric patients authorized to serve Dorchester County, 3 agencies account for the bulk of home health services delivered to county residents. Comedisys, Home Call, and Shore Home Care each serve multi-jurisdictional service area. Thus, even if VNA is successful in achieving significant market share in Dorchester County, this will have a relatively small overall impact on the volume of business provided by these agencies. The total estimated cost of this project is a modest $47,000. Commission staff recommends conditional approval of this project. The review of the project concluded that it complies with the applicable standards of the state health plan, that the project is needed and embodies a cost-effective approach to meeting the needs. Additionally, we believe the project is viable and will have a positive impact on the availability of home health care service delivery in Dorchester County. Staff recommends approval of this project with the following 2 conditions, which are standard for a project of this type. Number 1, VNA shall maintain compliance with provisions of COMAR 10-24-16-08E, subparagraphs 1 through 4, regarding charity care, sliding scale, and reduced fee services. Number 2, VNA shall provide an amount of charity care equivalent to the average amount of charity care provided by home health agencies in the multi-jurisdictional region it proposes to serve. And the 3rd condition is that VNA shall provide documentation regarding its links with hospitals, nursing homes, continuing care retirement communities, hospice programs, assisted living providers, adult evaluation and review services, adult daycare programs, the local Department of Social Services, and home-delivered meal programs located within its proposed service area when it requests first use approval. Before we go to questions, I'd like to introduce the applicant. Before us here today is Mr. Barry Ray, who is the CEO and administrator of VNA and the owner.
Mr. Ray, welcome to the commission.
And as well as Mr. Ray is Ms. Karen Hayes, who's the Director of Clinical Management, and Mr. Keith Hobbs, who's the Director of External Legislative Affairs.
Thank you so much for coming. Mr. Ray, do you have any comments? Pleasure to see you, sir.
Thank you. We at the VNA are very proud of the fact that we seem to be the largest home health agency in the state, and we, I think, have the most certificates of need, and it's something that we have spent. I personally have been here for close to 15 years and took the company from a very, shall we say, depressed state into its current operation. And we are a 5-star agency for quality and 4-star for patient outcomes. and something that we think that is very important. So we thank you for your consideration.
Absolutely. Karen, hey, do you have anything to say? Counselor? Right. Okay. Nobody here has to take the Fifth Amendment, so you're really not necessary.
They're not this way when we're in the office, I promise you.
Okay. Any commissioners have any questions? Commissioner Pollack.
So I can attest through my experience, my patients, to the quality of care that your agency provides. I think is absolutely outstanding. And I can also attest to the state of the agency when you took it over 15 years ago. It was substantially different at that point. So thank you for what you've done. I'm interested in understanding if there's any other evidence that the quality has been anything but outstanding, because we've seen everything but outstanding in the way of nothing but outstanding care and outstanding evaluations, which leads me to question why not solve rate, why we get chased out based on the opposition of an agency there. Are we really that averse to competition in the state? Is competition really a bad thing in this industry?
I can't comment on what Peninsula had in mind that would be inappropriate for me, although you can draw your own conclusions. My decision had to be made based on strictly business. Was it worth the aggravation, the time, the legal fees to fight what was proposed in some what I consider to be unfair and untruthful objections? But yet, the process as it currently stands allows for that to happen and puts the burden of proof upon the applicant, even though you have already established need, the commission has, and even though you have already established the quality standards, which we were able to show that we participated. But if you allow the legal community to object without any skin in the game, with there being no consequences to the people who do it, then you force me now as a provider to take away resources from providing for the care for the residents that we are currently asked to have to sit and answer these rather unfortunate allegations that, in my opinion, were totally baseless.
Thank you. Mr. Chairman, I just want for the record, I did not ask him that question in advance. That was spontaneous.
Mr. Pollack, I absolutely am convinced.
However, while I'm here, let me just say the CLN process is a very good one. It just needs, sorry, Dr. Pollack. I thought you might think that you might interpret that. The process is, the concept is correct, but the process needs to be modified in order to be able to allow people. They shouldn't be taking objections from people who have a vested interest in trying to keep people out. As having 17 CONs, you've opened up the process over the last few years, and I've lost employees and I've lost business. But that's life, and you've never seen me send in a interested party stature to try to keep someone out. Unless you've got pictures, there's absolutely no reason why that should happen if you've determined that there is a need. So I think that the application itself, and maybe if we had a party that worked together with setting that up, when you have existing agencies that have an outstanding record and are in every other county, making them go through these exercises are extraordinarily painful, difficult, and from my perspective, not worth the effort. I know that if I go into the other Salisbury and the other counties, I'm going to lose a significant amount of money. It's a 3 to 5 year investment to get it turned around to the point where it's going to operate properly. I'm not going to make that investment if everybody's, in my opinion, this information is open on the website. People could look and see what the allegations were. And frankly, I felt that it poisoned the water, and I wasn't about to go in and have to overcome that obstacle as well.
Thank you very much. Commissioner Trimarchio.
So one of my things I always look on a CON is where it says local government review and comment and community support. There's nothing there. I just want to point, I'm not judging this.
I understand.
That. I'm just highlighting it as another lost opportunity and something that speaks to a larger need too. So highlighting that. Thank you.
Commissioner Sargent.
I guess I have a comment rather than a question.
Fine.
And it really is, to me, this is a classic example of what's wrong with CON in the home health context. That the justification I've heard for CON.
Speak into the microphone.
The justification I've heard for home health CON is to keep quality up. Well, so we've got a quality provider who's not going into a county because a competitor has managed to block it with the process. That's a fundamental failure of the process. So we'll be making recommendations later in the year, but we actually have a quintessential example of what's wrong in this category that we should be considering when we're making recommendations to the legislature.
Thank you very much, Commissioner. Are there any further questions? Any questions at all? Okay, well then the issue before us is the approval of the certificate of need for the Visiting Nursing Association of Maryland for their program to establish a home health agency for residents in Dorchester County. Do I have a motion? I have a motion. I have a second. Are there any further? Is there any further discussion on the motion? Okay, fine. All those in favor of the motion, say aye. Aye. Any opposed? The ayes have it. Sir, you have your certificate of need.
I appreciate it. Thank you very much.
The next item is a certificate of need for the Joseph Ritchie House, Gilchrist Hospital Care has applied for a certificate of need to relocate and replace a 30-bed Joseph Ritchie House with a new 22-bed inpatient general hospice. Mariama Gondo, program manager, will present the staff recommendation. Ms. Gondo, thank you very much.
Thank you, Chairman Moffitt, and good afternoon, Commissioners.
Okay.
So, Gilchrist Hospice Care Incorporated and Joseph Ritchie House Incorporated proposed to relocate and replace Joseph Ritchie House, which is currently located in the Seton Hill neighborhood of Baltimore City near the campus of the University of Maryland Midtown campus, to Stadium Place on East 33rd Street. This location is about 3.3 miles north of this current location. The replacement facility will function as a combination general inpatient unit and a hospice house of Gilchrist. Gilchrist is the largest hospice provider in the state of Maryland and gained control of Joseph Ritchie House in 2014. However, Joseph Ritchie House has maintained a separate general hospice license. While Joseph Ritchie House historically provided general hospice services in recent years under Gilchrist's control, it has primarily operated as a hospice house. A hospice house is a residential treatment setting. A hospice house is a residential setting in which patients receive routine hospice care just as if they would living in their own home or apartment. In this case, Gilchrist staff has provided care under a contractual agreement with Joseph Ritchie House. Gilchrist plans to eventually consolidate its operations so that Joseph Ritchie House will no longer be a separately licensed hospice, but will function as a combination inpatient unit and hospice house. Gilchrist already operates 2 such facilities located in Towson and Columbia. Joseph Ritchie House was founded and has operated with a mission to serve indigent patients, including individuals who lack permanent housing or adequate or family and social support networks, and are often burdened with severe mental health disorders or battling an addiction with alcohol or drugs. Gilchrist has continued to operate Joseph Ritchie House with the service mission and proposes to continue to serve the special population at the new location. As a result, on a standalone basis, Joseph Ritchie House does not generate income from its operations. It lost $1.4 million in 2017 and projects a loss of $774,000 in the third year of operation at the replacement facility. However, Gilchrist is committed to subsidizing these losses. Gilchrist has a strong balance sheet. In fiscal year 2017, it had $21.5 million in current assets against $8.2 million in current liabilities and $6.4 million in cash and other liquid assets. Gilchrist has demonstrated strong operating performance with net income averaging about $3.8 million in recent years. It also raises between $4 and $5 million annually in philanthropic donations. The current Joseph Ritchie House is comprised of 2 repurposed row houses that are old, operationally inefficient, and do not lend themselves to cost-effective renovations. Gilchrist proposes construction of a $10.3 million replacement facility, largely funded through philanthropy and cash equity, that will maintain the same bed capacity it currently has. The size of this expenditure is the basis for the requirement that the Commission approves this project. Staff has concluded that the project complies with the applicable hospice standards of the State Health Plan and has demonstrated a need to modernize the Joseph Ritchie House facilities that require replacement in order to be cost-effective. With respect to quality, Gilchrist is currently accredited by the Community Health Accreditation Partner organization and is licensed and Medicare certified in good standing. With respect to the Consumer Assessment of Health Provider and Assistance Performance Survey, or CAP, which is a survey that evaluates a patient and family's experience of care and is publicly reported by CMS, Gilchrist's performance lags the national average on most of the reported measures. However, the variances between the national average were not large. Gilchrist has a quality assurance and improvement plan to monitor and address the areas that need performance improvement. As I've noted, Joseph Ritchie House is not expected to generate income for Gilchrist based on its intended model of operation, but we believe Gilchrist is fully capable of sustaining and continuing the Joseph Ritchie House service mission. Finally, we do not believe that this project which replaces but does not expand the capacity of Joseph Ritchie House will have a negative impact on other hospice providers or on costs and charges in the healthcare system. It will improve the setting in which hospice care is provided for Joseph Ritchie's traditional patient population. For these reasons, Commission staff recommends approval of this project. I want to introduce the applicant represented today is Catherine Hamill, who is the president of Gilchrist Hospice Care, Wayne Barth, who is the chief financial officer at Gilchrist, and legal consultant from Miles and Stockbridge, Jennifer Coyne.
Well, first of all, welcome all of you, panel and support. I was very struck by this application. Gilchrist is a very strong financially a strong institution. And the thing that really stands out, it's a strong private sector institution that is really serious about taking care of people who really need the most help. Their charitable work, and basically that's what we're asked to approve here, is a charitable contribution to the welfare of some of our most needy fellow citizens of Maryland. I'm very impressed by the application. But anyway, there are other members of the commission who may have some questions. Yes, Elizabeth. Yes.
Before we go, I'm going to recuse myself.
Pardon?
I'm going to recuse myself.
Okay. Commissioner Hasey has to recuse herself, which means you have to leave the room. Okay, very good. We'll call you when it's over. Yes, Commissioner Sargent.
I suspect most folks already know this, but I was struggling with the difference between between an inpatient bed in a hospice and a hospice house bed. Could you tell me what the difference between those two is?
No problem. So, as I said, the hospice house is a facility where patients who receive care, general hospice care, as if they were living in their own apartment or home. But they're usually there because they do not have a caregiver or someone at home to take care of them at the level of care they need. The hospice, the inpatient unit, is actually served for people who are unable, for people whose disease require extensive treatment or their palliative care requires more treatment than can be handled in a residential setting. They would go to an inpatient unit and receive that treatment there.
So it would be more like an inpatient hospital bed.
Correct. Or even in a skilled nursing center.
Thank you.
Okay. Commissioner Pollak?
Yeah, I just want to offer a thank you and an apology, but so the thank you is for doing this, for taking over this hospice and for moving it and for investing it and for continuing to provide philanthropic support to a center that desperately needs it. It provides a service to the community that couldn't be replaced. The hospital system would be overwhelmed with patients to a higher degree if you weren't doing what you're doing. And I would generally say that we provide very little additional value in a CON process for something like this, except to add to your cost of development. But in this case, I think it's provided an opportunity for the public to see exactly what you're doing, because I'm not sure that everybody understands it. Even not-for-profit organizations have to generate a positive margin, and to take on an organization that's going to drag that down on a continual basis because it's the right thing to do is a great thing. So thank you.
Any further questions? Any further questions? Okay. All right, the motion is to grant an approval of a certificate of need application for the Joseph Ritchie House. Do I have a motion? Okay. Do I have a second? Second? Okay. Any further discussion on the motion? Fine. All those in favor of approving the certificate of need application for the Joseph Ritchie House, say aye. Aye. Any opposed? Very good. The ayes have it. Thank you very, very much, folks, for stopping by. The certificate of need is yours.
Thank you.
Thank you. Okay. Commissioners, one of the duties we have is to make policy for the citizens of Maryland. The next item is a regulation, a final action on a regulation for privacy and security of protected health information in the health information exchanges. In February, the Commission adopted proposed regulations governing the privacy and security of sensitive health information. Information that is transmitted or stored by a health information exchange. This kind of information includes information that is particularly sensitive information where there would be a high risk in the event of disclosure. It's subject to additional federal protections beyond what we provide here in the state of Maryland. The proposed regulations have been open for comment, and we are now ready to consider adopting these regulations as final. I want to thank the many groups publicly who participated in the development of these proposed regulations. Alana Sutherland, Program Manager for the Center for Health Information Technology and Innovative Care Delivery, will present the regulation for final action. Alana?
Thank you very much.
The floor is yours.
Thank you, Mr. Chair and Commissioners. So, as the Chairman stated, today we are recommending that the Commission approve final amendments to COMAR 1025-18. In general, these regulations facilitate information sharing, and create safeguards for consumer health information. Maryland law has required that the Commission adopt regulations for the privacy and security of protected health information exchanged through an HIE in Maryland since 2011. The amendments to the regulations pertain to sensitive health information, or SHI, and the exchange of that information to improve care delivery and coordination. They are also intended to align with federal laws that require additional granular patient consent of the exchange of SHI. So the current regulations went into effect in March of 2014, and they've been amended twice since then, in 2016 and 2017. They enhance the privacy and security of patient information beyond the baseline that is required for HIPAA and HITECH. And the regulations require an HIE operating in the state of Maryland to register with MHCC annually. And we currently have 5 HIEs registered in the state falling under the purview of the regulations. So regarding sensitive health information, it includes subsets of protected health information that have specific federal or state legal protections assigned to them, in addition to those required by HIPAA. Examples would be things like genetic information, CFR Part 2 information related to substance use disorders, certain communicable diseases, and other conditions. And protections to SHI are important because of the risk of discrimination or social stigma or harm that are associated with it. So the purpose of the amendment is to ensure that patients with substance use disorders or other sensitive conditions are able to benefit from the sharing of their electronic health information for legitimate healthcare purposes. Providers are requesting SHI through their HIEs more frequently to provide efficient care delivery, and the amendments also seek to enable alternative care delivery models that are supported by the use of HIEs. So the amendments allow an HIE to exchange specific information through transmissions other than point-to-point, whereas the current regulations only allow an HIE to use point-to-point transmission to exchange SHI. And point-to-point transmission is essentially a message or a secure email from one provider to another that includes specific patient consent. So the amendments aim to assure that the SHI transmitted adheres to state and federal laws, and that specific granular patient consent is collected in terms of who it will be disclosed to, what information will be disclosed, and the timeline for disclosure. Patient consent choices must accompany the SHI transmitted by an HIE and disclosed to the authorized provider. The amendments also align with federal regulations, in particular the HHS update to 42 CFR Part 2, which relates to the disclosure of information pertaining to federally funded programs related to substance use disorder treatment services. And the changes allow for better information sharing. It allows Part 2 providers to take advantage of newer care delivery models and to take part in HIE. So to develop the amendments, we worked with the HIE Policy Board, which is a staff advisory work group, and they helped us to develop the policies that serve as the framework for the amendments. The work group consists of a diverse group of stakeholders, including representatives from business organizations, payers, providers, public health, and HIEs. And the formal comments were sought in June. We received 2 letters of support from the Behavioral Health System of Baltimore and the Maryland Hospital Association. We also received a 3rd letter from RadNet seeking clarification as to whether or not the amendments pertain to their organization. And the comment letters are available in your packet. Staff also recommends that a non-substantive change be made to the definition of payer in the regulations to align with the definition in statute. The change specifies that a health maintenance organization and nonprofit health service plans hold a certificate of authority as opposed to stating that they are licensed in the state. So staff recommends that the Commission adopt the proposed amendments as final. with one non-substantive change, and if approved, the amendments will become effective August 13th. Thank you.
Thank you very much, Ms. Sutherland. Commissioners, does any one of you have any questions for Ms. Sutherland? Okay, we've been working on this actually for quite some time, so you're all very comfortable with all of this. So, okay, thank you very, very much. Alana, thank you very, very much for the hard work on this. I want to remind the commissioners on this particular regulatory action we're about to take. The Administrative, Executive, and Legislative Review Committee of the General Assembly has a few more days to review the proposed regulation. And for that reason, when we vote on this regulation today, my signature on this as a final regulation for the Commission will not be effective until July 24th, 2018. So everybody understands that, okay? Now let me ask you this, does anybody have a motion to approve? All right, we have one motion. Second, we have a second. All those in favor of adopting COMAR 1025-18, privacy and security of protected health information, sensitive health information regulations as final regulations, say aye. Any opposed? The ayes have it. Thank you very, very much, Alana. Okay. Our next item has to do with the state recognition of an electronic advance directive. Earlier this year, the Commission adopted COMAR 1025-19, state recognition of an electronic advance directive service. These regulations require that an electronic advance directive meets certain privacy and security standards. If that advance directive service operates through the state designated health information exchange. This past spring, the Commission opened up the application process for electronic advance directive services. Since that time, AdVault Incorporated, which is a Texas firm, is seeking state recognition for its electronic advance directive services here in Maryland. Nikki Majewski, I got that right, Chief of Health Information Technology, will present the application and the staff recommendation. Nikki, thank you.
Thank you. Good afternoon, Mr. Chairman, Commissioners. So as Bob just mentioned, the regulations were passed this past March. State recognition is a component of a broader statewide initiative that aims to facilitate use of cloud-based technology to support creation of and accessibility to electronic advance directives. It is a prerequisite for connecting to the state-designated HIE CRIS, and it is valid for 3 years. Some background information on how we got here for some of the folks who are new around the table. In 2015, legislation was passed supporting electronic advance directives, providing an alternative way for witness requirements on an electronic advance directive. In the following years, during the 2016 and 17 sessions, legislation was passed to establish the statewide initiative that I just mentioned, and that included a task for MHCC to develop vendor criteria for state recognition. We worked collaboratively with stakeholders, including some vendors who might seek state recognition, and their feedback was considered in drafting the regulations and the criteria. So here we are with our first application submitted by AdVault. They were founded in 2007, and their mission is to empower consumers to have a voice in their healthcare. MyDirectives.com was launched in 2012, and it's a free web-based application for consumers to create, update, and store and share their electronic advance directives. AdVault was also competitively selected back in 2013 to integrate its solution with CRIS, where providers could query advanced directives on their repository through the CRIS Query Portal. Some key Key components of the application include that the vendor has an independent third-party privacy and security audit each year, which includes an evaluation of their procedural and technical controls for safeguarding PHI, procedures for disaster recovery, business continuity, and cybersecurity, and then breach notification to consumers, which is consistent with the state and federal requirement of 60 days after discovery. They are also, their software and data storage vendor ClearData undergoes an annual SOC 2 audit, and SOC 2 is a widely accepted across the industry, and it's designed for service providers storing consumer data, and it has an approach where there's trust principles and basically make sure vendors have well-defined procedures for information security. ClearData is also HITRUST certified, and AB Vault is in the process of obtaining HITRUST certification. And unlike an audit, HITRUST is more of a risk management approach that is very prescriptive, and it uses a universal cybersecurity framework that kind of has a comprehensive baseline for security controls. And it's becoming increasingly accepted and adopted across the healthcare industry. The vendor also allows electronic advanced directives to be downloaded, printed, transferred, or deleted. They have video capabilities and audit tools to track when electronic advanced directives are retrieved or updated or deleted. And then they also have established guidelines for communicating to end users, and as well as protocols for the transfer of electronic advanced directives if they were to be sold or go out of business. Development activities are planned to support paper advanced directives, and they will also be implementing NIST authentication standards within 12 months of receiving state recognition. So that concludes my presentation, and we recommend that the Commission grant recommendation or grant state recognition to AB Vault.
Okay, fine, thank you. Thank you very, very much, Ms. Krzyzewski. Commissioners, are there any questions? Commissioner Sargent.
This is not the only one, right? I mean, we're not selecting the one recognition. It's more.
No, so this could allow for multiple vendors. There are some others that could come to the table.
Commissioner Pollock?
I'm sure I've heard this before, but can you explain how the provider accesses this information? So I'm working in an emergency room. How do I get to this?
So it's within the CRIS query portal workflow, and you basically click a tab that allows them to kind of securely go to their repository. So it retrieves an information. It'll say, does an advanced directive for this person exist? And then it'll allow you to view that. It'll say one exists, and you can click.
And it'll allow me to do videos if they've uploaded videos?
Yes.
Right for CRIS.
Yeah. It's through the work. So it takes you outside securely to their repository.
So I enter it through CRIS, but I
Yeah.
get into their
Yeah,
platform.
exactly.
That makes sense. Okay.
Yeah, CRIS does not store any of this.
Well, it doesn't have a viewer side of it either. So it's one about
Yeah.
the videos. So that makes sense.
Commissioner Boyle.
Thank you. It's interesting. As a patient, how would I even know this exists, or that I have the ability to share my directive if I am so inclined?
So this vendor exists today, and they have different arrangements already with providers in the community. They have partnered with Howard County on a easy campaign for the Horizon Foundation. So many consumers already know about my directives and have created advanced directives. The concept of CRIS is not quite clear, but there is the other component of the statewide initiative is an outreach and education component that the Department of Health is handling, and they are encouraging the benefits of electronic advanced directives and how, if you choose a recognized vendor, once we have one, how that information is more accessible to hospitals if you were to end up in an emergency room, because it's able to push that directive to them without getting into the nuances of CRIS and what all that means.
Will physicians bring this up with patients, or state lawyers? How I define?
Yeah, so there's the department has several grants with different organizations in the community. They started with faith-based organizations, and now they're with different community providers, and it's more focused at this point on encouraging them to have the conversation and pointing them to tools they can use like this.
Commissioner?
So what we heard earlier in the educational session about the total cost of care initiative puts the onus, at least for the Medicare population, which is the population largely that we're talking about here, the onus of the cost of care for that population on the hospital. And every Medicare patient is attributed to one of the hospital organizations in the state. So there's tremendous incentive on the part of the hospital to make sure that at least that patient population is aware of this option. And I wouldn't be surprised to see organized educational programs through the hospitals around this exactly this type of thing in order to achieve it. This is 20% of the cost of Medicare, is that right?
25%.
25% of the cost of Medicare.
End-of-life care.
There's definitely a lot of activity going on, and now that once we have a recognized vendor, there can be more acknowledging of saying, go here and create one. But
or we'll have our case managers help you do it if you need to.
Mm-hmm. Yeah.
The other thing I would just mention, and we've talked about this before, but I think it's vitally important for you to reach out to social service institutions and religious institutions in particular who have a very, very strong interest in end-of-life care directives.
Yes.
To make sure, that they're in accordance with whatever the ethical, moral, or religious convictions of the patient are. The important thing is that is where there's a tremendous potential, I think, for serious outreach on this.
Mm-hmm.
And I hope we do it. But
they have been in the department for almost 2 years now.
Very
That's
good.
where they started, and they've kind of branched out a bit.
That's
but
good.
It's a hard conversation. So many,
Yes.
I think it's about 75% say this is great, but only a third of them go
That's
on
correct.
to do this. So
I've seen the same numbers. That's
not
exactly
easy,
right.
but
Yep. Yes, Commissioner Hammerslough.
Just kind of a sidebar thought is that I know that this is a Texas-based firm, but in working in long-term care settings and whatnot, I'm so used to using the MOLST form, which is a different kind of version of, and I'm wondering, and you may not have the answer, but kind of thinking through not just advanced directives, but we have the system for the MOLST in Maryland that's really good at driving some of these conversations and thinking through how that might integrate into all of this.
yes, it's been discussed for several years. Actually, this work, that's when it first started back in 2011, came from a work group discussion that looked at both advanced directives and MOLST, and it thought HIE was a good means to communicate end-of-life treatment preferences. The focus was on advanced directives, but MOLST has always kind of been of interest, and it recently came up again in conversation about creating a new registry, so I wouldn't be surprised.
Commissioner.
Your comment about in the ER made me think of it. I've worked in the ER, and I don't have time to watch a 15-minute video before I decide what to do, but the MOLST is really helpful.
Yeah, it is. But if the patient has gone to the length of creating a video that describes what his or her particular
Yeah.
wants
No,
to
absolutely.
have access to.
Absolutely.
Very, very good. Any further questions? Any further questions at all? Nikki, thank you very much. By the way, I just commend you for a lot of the work on this. I think this, once again, I don't want to sound like a broken record, but it's another area where the state of Maryland is actually basically head of the nation. And we ought to be proud of that because we've had something to do with it. Yes. Oh, that's right. We have an action item. Sorry. That's right. We have these people have applied. We have to decide whether they should get it. Okay. The question is the approval of state recognition of an electronic advanced directive for AD Volt Incorporated. So, do I have a motion? Motion. Second. Second. All those in favor, say aye. Aye. Any opposed? All right.
Thank you.
Tell the Texans we're behind them.
Okay, I'm sure they're on the line. Sure.
Okay. All right. The next item has to do with price transparency. Last October, the Commission launched a new consumer-centric website called Where the Cost, The purpose was to provide meaningful and useful information for patients on the cost of healthcare in Maryland. Since that time, the Commission established a working group to obtain input and advice and counsel from various stakeholder groups and consumer groups with different expertise on the episodes of care. It also included representatives of the medical community. Today, Mahi Nagatu, do I have that correct? Okay. Chief of Policy, Cross-Payer and Workforce Analysis will present the upgraded Where the Cost website. Mahi, the floor is yours.
Thanks, Chairman. Good afternoon, Commissioners. I'm filling in for Linda Fortniska, my boss. These are her slides, and unfortunately, she wasn't able to be here today. So, as Chairman mentioned, we just relaunched Where the Cost today with the inclusion of commercial 2015-16 data and additional redesign of the website. So this presentation is to show the new upgraded website. So what I'll do is go over the slides briefly and give you the Where the Cost 2.0 site tour. So just to give a background of the Where the Cost goals and objectives, it's a consumer-centric website that provides price and quality for Marylanders to enable them to compare hospitals and providers for common medical procedures. And it does this by promoting shopping for value by providing cost and quality information associated with an entire episode of care. It educates consumers not just about cost, but also the variation that exists among providers and the current reporting among hospitals. It also keeps consumers engaged in various ways, such as social media and by linking up resources that will enable consumers to change the information that's available into action. So just to give you a background of the grouper that we use, Where the Cost uses the proprietary episode of care grouper software, Prometheus, created by HCI3, that's Healthcare Incentive Improvement Institute, which is now a division of AllCare. When within Prometheus, it bundles costs of all services associated with an entire episode of care, and the costs associated with potentially avoidable complication. These are harmful events that could harm the patient and could be avoided. Path rate is the proportion of the episode that includes one or more events and is reported as quality along with readmission rate on the Where the Cost site. So during the October release, we had 2014-15 data, and the site went through a very intensive user acceptance testing and also data review with the hospitals. So based on the feedback from the hospitals and also consumers and other stakeholders, this phase of the release involves upgrades to many aspects of the website and the actual data review process that we had with the hospitals. So what is included in the upgrade? So the first thing is, since the target audience is consumers, it defines an action step for consumers to show their support by signing an appeal to doctors, hospitals, insurance companies to work together to make all costs public and provide the highest quality of care at the lowest possible cost. The other action that's added now is a new functionality that will enable consumers to download the data in a report form or a raw data form. So the report will enable consumers to take the data, compare hospitals, and possibly discuss price with their providers. And the raw data is for researchers, and what it does is
captures all the data that's publicly displayed on the site and generates a CSV file. So as you know, there was an introductory video that was part of the initial release. So that video has also been modified and simplified, and also the example provided in the video is modified so that it's more clinically relevant. The other section of the upgrade was the simplification of the tables that was part of the initial release. So the cost and quality table, as I will show you in the demo, the initial release included various columns that were kind of overwhelming and confusing for consumers. So we had to kind of downsize and simplify it so that it's more valuable. So the other biggest upgrade of the site is the scalability. So when we say scalability, it might not be relevant when you look at it now, but it will be more relevant when we keep on adding new data to it. So we have made the website more scalable in 3 aspects. One is adding data within the same payer cohorts, meaning adding, like for instance, what we just did, adding 2015-16 data, adding more payer cohorts, for example, including Medicare in the future, and adding more episode groups. So there are 3 different aspects of the scalability. And also, this time around, we have a full functional work group that includes physicians and other stakeholders who have been providing us a very valuable feedback to improve the website for this release. So I'll go to the website and to show you what the new changes are. So this site was released today, and as you can see, the initial landing page also has changed, and it starts with making the statement that we need to talk about costs. So it follows by the individual episode pages, which look like small cards, and currently, since we report on the 4 procedural episodes, you can see them right on the landing page. So taking hysterectomy as an example, clicking on it takes us to the individual episode page. So pretty much this is the same as what we had initially, and what it does is it defaults to the current year data. So now we're looking at the commercial 15-16. So it starts with the statewide average, shows the high and the low. So this is an IE compatibility issue that we have, but it doesn't happen on other browsers. And this pretty much stayed the same. And here is the other upgrade that we did, where users can now toggle between 2014-15 and 2015-16 year data. So that's part of the new scalability design. As part of the enhancement, now we have the cost breakdown definitions are included. That means, in other words, what type of cost goes into each of these buckets. So a consumer could look at that breakdown by clicking on this link. So one thing that I want to add, we have more number of hospitals this time around because we were able to expand the data study window period to include episodes that ended in 15-16 regardless of when they began, instead of just looking at episodes that began and end within that 2-year window. So scrolling down to this the quality section. Here we have the same toggling capability, but also this is the section that that shows the table that's downsized and simplified to just show 2 fields, which was initially around 6, because we had the breakdown of the cost by typical and expected, and also episode value, which was a little bit irrelevant for consumers and was kind of confusing. So this is pretty much it for the individual episode pages. This is kind of the same for all the episode pages, meaning like this information kind of replicates except that the number changed. And the other bigger section of the current upgrade of the redesign is the consumer engagement section. So which is join the conversation, which you can access from the top menu or from this banner down here. So the join the conversation section initially had, or the I should say the consumer engagement section had the join the conversation and additional blog. Now those two have been combined, and we have everything in one page, and which enables consumers to have access to all things at one place, making it more intuitive and engaging. So one of the biggest changes that we added, not a change but an addition, was the sign the appeal, as I mentioned earlier, which can be found here, and also the download capability. Consumers could also get their own t-shirts. This is a new functionality that we added this time around, and clicking on it, they could go to this website where they could find and order a t-shirt. So this is pretty much the new look, and it also shows the Maryland Comparisons website benchmark table, where we can see how Maryland fares out with other states, Connecticut and Colorado. That concludes my presentation. Thank you.
Ms. Delgado, thank you very, very much. And thanks for filling in for Linda. Commissioners, do you have any questions for Ms. Delgado? Yes. Commissioner Wang.
First of all, I want to say congratulations to you and Linda and the whole team, because I think this is one of my favorite things that the Commission does. It's so consumer-focused and consumer-centric. The presentation is good. It's kind of what Commissioner Sargent was saying earlier. We have so much great data here, but it's hard to kind of get it to people. It's like kind of fill a teacup with a fire hose. So this is great. And, you know, with regards to awareness of the T-shirts, I want you to know I actually wore your T-shirt to the gym. So I really wanted to make people aware of where the costs and how much a vaginal delivery could cost you on average. $10,800, you know, and now it's up to $11,000. But you know, I did my part. So my question,
yes,
you sure did. Yeah, you know, I can pull it off. I mean, but my question for you is, what kind of data are we collecting on how people are finding the site? How long the bounce rate? How long they're staying on the site? How are we getting the word out? Because more people ought to know about it.
So the social media engagement part is where we have a lot of interaction, but also we have implemented a new and more enhanced Google Analytics report, where it gives us the breakdown by gender and by actual individual section of the website. So let's say someone is reading the blog section, we would know what their interests are. So we did a similar breakdown of the audience in the previous site, and most of so for episodes like vaginal delivery and hysterectomy, we had a lot of returning viewers, and for knee replacement and hip replacement, it's just the first-time viewers, and that was also stratified by age group. So obviously these are older generation, and also we have Marylanders and neighboring states that are interested in looking at the data. So we will be reporting the new breakdown of that Google audience report in the next month, and we'll see how much traction we're getting.
Mr. Director.
So unrelated to this, we just were notified by the police that a a silver gray SUV with license number, I assume it's Maryland 2D89044, was hit in the parking lot. So if you have the police, no, silver light. It's on the to what I would call the south. By okay. Anyone else know those numbers? Anyway, all part of the meeting. I don't know if Leslie Lebrecht has anything more to add on this. Well, why don't you come up? I don't think we can hear you unless you do. But people on the line on the.
Well, he summed up the analytic part quite well. And Altarum has been engaged. They're helping us with outreach activities. Most of the county health departments are on board with this. In addition, we have a pretty robust media outreach plan that's been engaged, and our partners within that plan have agreed to distribute a social media kit that was developed, that we developed as part of this project, and we're hitting the media outlets in the most cost-effective way that we possibly can.
Thank you. I would note Commissioner Wong's point that farmers markets make very interesting places to wear a T-shirt if any commissioner would like to receive one or even borrow one. That's a good location from experience, I know. But to the point of social media, this is a test case. We did Altarum as our contractor on this effort, and they worked. They have a communications director, and they with Megan worked to engage the media over the last several days. I've had interviews with the Wall Street Journal, with Baltimore Business. An article came in on Baltimore Business referencing that site this morning, Fierce Health, and I understand the Daily Record had a story. Apparently, I ended up on the cutting room floor with the Wall Street Journal, but we can still be optimistic. But it does demonstrate that we can put more energy into these efforts, and they do yield results. But it does take some time, and it does take staff resources to do this. So the entire organization, along with their consultant, working together, did generate some momentum. The challenge is maintaining this momentum, and that was one of the questions that I believe it was the Baltimore Business Journal asked us. Is yes, we had 5,000 visits the first week, but it tails off, and clearly adding new items, working with media and other outlets is really important to keep generating interest going forward on this. It's an important national conversation, and I think it's one for Maryland as we move into this new model that we have to recognize that, as I said earlier, getting people excited about the Medicare performance adjustment or the global budget revenue level for your hospital is not, but it's the fact that you have great variations in cost and significant differences in quality are issues that patients care a lot about.
I just mentioned, oh yes, Commissioner Tamarkio first, go ahead.
So the last time we had the release of this information, there was expressed concerns by hospitals here So where are we today with that? How's the feedback from hospitals? Are any of them taking advantage of this wonderful marketing opportunity to highlight that while they might be a smaller hospital, they have the best prices?
Megan?
Yes.
So I was first going to start and say that we've done, and this is not my work, this is Leslie's work. I did a lot of work to try to engage hospitals more actively in the updates. We tried to engage them the first time around, but just I think we've gotten better engagement since. So they saw this update before it launched. They had a chance to double check their data, and the MHA has been actively involved too. I think there's still a little bit of nervousness. I was expecting to hear back. I don't know for sure. I know they had a meeting with members this morning, so I haven't heard back from that. So, but I do think we've done a much better job of sort of keeping the communication lines open throughout, so that that's not, there was, to mitigate some of the issues we have last time. Does that answer your question? Oh, we had one workers member who is from a low-cost hospital who certainly talked about his using it while talking to physicians. So I think there is, I think the low-cost hospitals do see that there's merit in the information.
I just make a comment. Okay, Dr. McCarthy? Somebody else? Oh, okay. I'm sorry. Commissioner.
I'm sorry. I guess the only comment I have is obviously this is great data for the public to see, but obviously the payers are extremely important for them. But I would imagine they have their own data sources that they're gathering, and they're doing their own analysis, and they're making a lot of those decisions. So as a consumer, obviously, these things are important, but we're back to the payers having to make those decisions. And the bottom line is, you know, can we still overall meet these cost goals? And the payers are going to eventually decide some of this, how this data really pans out as far as covering an insured population. So I think it's good consumer information, but a lot of times consumers don't really have much choice in that.
That's correct. And that is, you're talking about a fundamental structural difficulty with the insurance markets in the United States, which are in fact not consumer driven. There are a lot of reasons for that, most of them based in the existing federal tax treatment of the health insurance. But nonetheless, your point is quite right. I would just simply say that the most important thing that I think has come out of this is the truth, which is we do not have a functioning market in healthcare. What we have is we have radically disparate pricing in many cases, which is utterly mysterious. People have known for years when they get their hospital bills that they simply don't make any sense to them. And at the same time, it doesn't make sense why, for example, a common medical procedure should cost dramatically much more in one geographic area compared to another one in the same geographic area. And the most important thing is, as I think from the very beginning of this conversation, what we want consumers to do is to start to ask the question, why this is true. And, you know, there are going to, policy answers are ultimately going to come out of that, but they won't come out of it until we start to actually shine the light on the truth. And this information is truthful. Commissioner Sargent.
So we started with 4 episodes. How many are we at now?
Still 4.
Oh, still
Yeah,
4?
yeah, but we are in the process of adding Medicare. So we're planning to include 5 more and proceed with that for the next commercial release.
What is, to add a new episode of care, what is involved? I mean, is there like a pre-existing list somewhere of like what, this is what constitutes episodes and conditions that you can just run the data through, or do you have to actually define all of the codes that go with each episode in the condition?
So the software generates all types of episodes, so a total of 94 or so. So we started out with procedural episodes because those are the ones that could be attributed to hospitals. But within those, like Prometheus generates 30 episode groups within the procedure episode category. And what we do after we receive the data is there are some guardrails that are applied to the data just to make sure that it's the completeness of the episode so that we could calculate the risk-adjusted results. So when we do that, we want to make sure that there's no misrepresentation of hospitals so we have to apply certain thresholds. So when we do that, we wanted to make sure these procedure episodes have a sound variation so that it's worth reporting. So we would start out with 4, but eventually we are able to identify more volume of episodes, we'll be able to report additional ones.
So if one of the challenges is that if we have what we believe are significant incomplete episodes, it can mischaracterize the entity that is presented in a way that, of course, makes everyone else unhappy. So we're being careful about this. If you look at what organizations like the Healthcare Cost Institute do, which is an organization out of Washington, D.C., now headed by Niall Brennan, who used to be at CMS, they show many more episodes, but they don't disclose who the providers are. They just show variation. Linda and I have been talking about that, doing more, but only unveiling episodes where we've had confidence that it was fair. I think that we spent a lot of time trying to be fair. The other area that we want to move into is to compare services that are performed in using the Maryland parlance of regulated and unregulated space, which is regulated under the global budget model versus basically market regulated hospital-based, outpatient-based services are much more expensive compared to, say, for example, ambulatory surgery-based services here in Maryland, as they are in the rest of the country. And we think that's probably oftentimes not apparent to consumers when they're selecting their site of care. What we've run into is a bit of a challenge picking up the facility charge for ambulatory surgery centers. So where we would expect a ratio of maybe 1.5 to 1, we've seen ratios of 3 to 1, which is just too great. So we've been cautious. We started out, Commissioner DiMarcio raised a question about where colonoscopies, and that was an instance where we ran into some problems because we didn't have the complete set of data, but we're continuing to focus on that because I think variations across site of service and those site of service differentials are where patients can really gain some value.
Commissioner Pollack.
Can you explain it to me about 1.5 to 1, 3 to 1? I didn't follow that.
So what we would expect is the episode cost in a hospital outpatient department is about 150% of what the cost would be for the similar service delivered in a ASC. Considering all the total cost of care, not just the facility fee, the total cost, the anesthesiologist, the surgeon, the facility cost, and we're seeing significant greater variation because we were not able to pick up the facility fee in the ambulatory surgery center in all cases.
Yeah, our analyses, I can tell you, in comparing what an ASC would generate revenue versus a hospital outpatient department, is that the 3 to 1 is correct.
But when you add all the costs in, you might find when you actually add in the surgeon cost, the anesthesiology cost, those would be constant between sites of care generally because they're paid on the same fee schedule basis. So yeah, I'd be interested. We can talk further about this, but we are missing there is no facility charge at all in some instances because of the way people like Randy Sargent report their data. It's just the way data is reported. We're working with Care First and others, Kaiser, to make sure we have that clearly spelled out.
So I would encourage you
Mr.
to.
Sargent, yes, you can defend yourself.
That's all right.
First Amendment.
I guess I'd like to see like what is our plan to ramp it up? Because I think the 4 episodes are great, but they're 4 episodes, right? I mean, to make this a really useful tool, we're going to have to expand beyond the people who have those 4 episodes of care to something that's much more general. Come here, you may have this, and search for it. So.
We agree. And thankfully we don't have a meeting in August, but in September we'll come back with you on our plan.
And I think the commercial payers very much support this. I mean, payers may have data, but it's not true that the payers aren't, at least not in my experience, are not directing people to which hospital they go to. We're not. Especially with Maryland, it's an all-payer system. They're pretty much all in all the networks, and the doctors decide what they're going to do. So, and then the hospitals don't want their negotiated rates with payers put out anywhere. So there's limitations on what individual payers can do with handing data out to consumers. So this is a way for the consumer to see what the actual costs are without having to get into confidential data that the hospitals would object to our handing out on the street corner.
Commissioner Boyle.
Can you hear me? I'm short, so it's hard to think back to this. I mean, I think it's great data, wonderful information. Love your website. I have one caveat is where the cost isn't intuitive. You know your costs, join the conversation about costs. I don't know why that was chosen. I hope it's not getting in the way of people understanding how important this is.
I'll release that for Ben.
I think Ben explained it really well in an interview yesterday, so I encourage you to.
Go ahead.
So I think part of it is about getting consumers to take ownership. So it's really about, particularly in a market that's designed in a way that doesn't really encourage us to do that. So to think about really taking on to the point of wearing it, the issue of cost globally with respect to healthcare.
So when we have added a Google ad that actually if someone searches for costs in Maryland, it's the first thing that shows up. So it's regardless of the name itself, it's available for if anything related to healthcare costs, it's something that shows up on top of the list, which kind of also helps with the ad.
So not to stretch this too far, but the idea behind where the cost, and I think this was really Linda Barniska's idea, and it did go back and forth on a number of own the cost. Some people have actually borrowed this phrase, so I think it does have some granularity, but in a woman named Regina Holiday does some work, a former commissioner, Diane Stollenberg talked publicly about this, where Regina does actually paint. She's a Maryland resident, lives, I believe, in Garrett County, where she does artwork and actually paints people's stories. And if you go to health policy meetings, you have these meetings, you'll have these, rather attractive coats with people's healthcare stories on them. And, we're not trying to do that, but you're turning people in a sense into walking billboards to say, take accountability by actually wearing a t-shirt, as Commissioner Wang did. And, I've done it, maybe less recklessly, but I think that's the point of it, that we want people to take action. Wearing those costs is one way. Signing an appeal is another way, to your point. Being a little more dramatic and exciting. We do in a very, very useful site. Courtney presented that, but this is an experiment as much as anything, because we are taking a perspective on the site that Courtney presents on the very great work that we do and Teresa's team does. There's lots of information on price and quality, but we're taking a very much straight down the line perspective. These are the costs, whereas where the cost has a orientation, and that's I think going forward we're going to see how we put those two concepts together.
I would just say, and I want to remind the commissioners of all of this, that since we launched this effort last year, I think it's fair to say that it has attracted very serious national attention. I think you all know that, especially you, Megan, because you've been following the media. But there was a letter. Members of the Senate, Republicans and Democrats, don't agree on the rainfall, but once in a while they get the Democrats are on about this. But anyway, what happened is that there was a caucus between Senator McCaskill of Missouri and Senator Cassidy of Louisiana, and they formed a caucus which is actually functioning right now to explore the whole area of improving transparency in the healthcare system, including price transparency. What was significant is in their round-robin letter, they talked about breakthroughs around the country in transparency, and of course Maryland was highlighted as one of the states in the union where this was a major initiative. So we have a lot to be proud of. I think we are taking some very, very big steps. As we learned from the very, very beginning, this is an area that requires a high degree of care. We have to make sure that we do not have the substance of our point or the substance of our argument dragged down by methodological debates that nobody normally can understand. So we have taken pains to make sure that we're in constant contact with the different stakeholder groups, physicians and hospital officials, to make sure that what we put out there with our signature on it is the best we can do based on the data that we have. And I think they respect that. I don't think they're entirely happy all the time with this, but as you can recall, when you were in 5th grade, the report card time was always a time of anxiety. Right? So, we can expect that. But I think we've really made some very, very serious progress in this area, and we're going to continue to do so. We continue to do so, and we get this right as time goes on, and we start to expand the number of shoppable, identifiable items. We really will set a benchmark for the rest of the country in this area. Are there any further questions at all? Thank you very, very much. Thank you.
One about whether there's any interest in this by primary care docs or referring specialists.
We haven't tried exactly to cross-fertilize this with primary care providers, but it's a good idea. Megan made the point that a couple of the hospital executives did use it to point out that they were a low-price platform for providing surgeries, and I think he thought it got them some traction.
If you had a statewide program where primary care docs got incentives based on the total cost of care of their members, they might be interested in the amount of cost.
You got a
job for the insurance industry.
You got a point there.
Yeah, right. Okay. Thank you very, very much, ladies. That's wonderful. The next item is school-based teletherapy for special educational services, enhancing school-based healthcare services through telehealth. This has to do with a grant announcement. Ladies and gentlemen, the commission released announcements for grant applications for school-based telehealth. Justin Springer, program manager for the Center for Health Information Technology and Innovative Care Delivery, is going to provide some background information on, and also the grant objectives. Justine, thank you very much for showing up, and tell us what we need to know about telehealth grants.
Okay, thank you, Chairman and Commissioners. So a little bit of background on telehealth grants for those of you who are new, MHCC has awarded grants to 14 organizations to demonstrate the impact of telehealth and mHealth in a variety of settings. These grants have helped to complement existing efforts to expand health information technology in the state and help to inform better practices, industry implementation and expansion efforts, policies to support the advancement of telehealth, and the design of telehealth programs across the state. So as the chairman mentioned, on July 11th, MHCC released 2 new grant announcements: school-based teletherapy for special education and enhancing school-based healthcare services via telehealth. For those of you who may not know, the term teletherapy is defined as the application of telecommunications technology to deliver professional services at a distance, and is intended to include both non-medical therapeutic services such as psychoeducational assessments and non-clinical services such as speech therapy. School-based telehealth involves the use of telecommunications, including interactive video conferencing and store and forward transmissions, to deliver a variety of healthcare and other services to children in a school. The grantees will implement their projects for 18 cumulative months. So grantees will be permitted to kind of pause their grant during times when school is not in session, like the summer, if services are not being provided during that time, and then be able to take back up the grant when school is back in session and run for 18 active months. Applications are due on August 15th, and an award is anticipated in October. Awards will be for up to $150,000 with up to an additional $50,000 if the applicant is able to provide a reasonable match. To make potential applicants aware of the announcements, notice was provided via email to a broad distribution list that included a variety of stakeholders, including schools. A press release and social media were also utilized to ensure a broad notice. So for the school-based teletherapy grant, this aims to assess the impact of teletherapy to expand Maryland schools' access to qualified providers who can deliver specialized services to better meet the needs of students eligible for special education. Federal and state laws require that each child with a disability has an individualized education program, or IEP, that is designed to meet their unique and individual needs. In Maryland, special education has annually been reported as a shortage area since 1997, and the Maryland State Department of Education categorized special education as a critical shortage area for the 2016-17 school year. There's evidence that suggests the use of teletherapy for delivery of services can be equivalent and in some cases more effective as in person. It can also help assist schools, districts, local education agencies that might be struggling to find qualified specialists to provide services to students with special needs to meet these federal mandates. Some Maryland schools are already looking to teletherapy to address some of these special education shortages. So the school-based telehealth grant aims to assess the impact of telehealth to enhance the delivery of healthcare services and increase students' access to healthcare providers at Maryland schools to improve health quality and decrease absenteeism. All Maryland local school systems are required to have designated school health professionals available on site to provide healthcare services to students, which can be defined as a physician, a certified nurse practitioner, or a registered nurse with experience and/or training in working with students or school health programs. Schools can meet these requirements by having a licensed professional, which is usually a registered nurse at each school, or by having an unlicensed trained professional at the school working under the direct supervision of a licensed professional who is responsible for several schools. Telehealth has the potential to complement and expand schools' capacity to meet the students' healthcare needs by using technology to connect students to remote providers and increase access to services, including primary and specialty somatic care, chronic care management, and behavioral and mental health services, among others. There is evidence that school-based telehealth can improve health quality and academic performance of the student population and decrease absenteeism by addressing healthcare needs of students at the school, thereby ensuring that students are able to have access to their needed healthcare services and care is delivered in a timely manner. Staff actually was able to visit one of the school-based health centers that's currently doing telehealth in Maryland, and able to see the impact that telehealth can have on students. So I'm going to give a little story. A child came to the school nurse. The child was new to school. It was his first day of school. The family recently moved to Maryland. So the nurse saw the child and determined that he needed to see a provider. The child was enrolled in the telehealth program. So the parent was contacted for permission to conduct a visit via telehealth. This is done with every student. The parent has the option, can actually participate in the telehealth visit. So it has that capability to do three-way. Once the consent was obtained from the parent, the nurse contacted an ED doc at Howard County General and was able to get the child seen via telehealth that day. The child was given a prescription that was sent to the parent's pharmacy of choice. And even though this child had to be excluded from school, this kind of facilitated faster return time to school because the child was already seen by a doctor when he left the school and had a prescription already waiting. So he was able to start treatment right away and return to school quicker. So the timeline is from August to October. Staff will evaluate proposals, and also external evaluation panel will review the proposals as well. We anticipate making an award in October. November, the projects will launch. In April of 2019, they anticipate to go live with the technology. In November of 2019, an implementation progress and preliminary outcome summary will be available, and then release of the final report is anticipated in the summer of 2020. And I can answer any questions.
Any questions from any members of the commission? Presentation? Anything at all? Well, while you're ahead. Thank you very much, Ms. Berger. Terrific work. Thank you very much. Okay. Ladies and gentlemen, we have some upcoming initiatives, and I'll turn this over to Ben Steffen, who will talk about what will happen. I will tell you, you probably know this already, but in August, we will not have a commission meeting. We will be taking off in August and returning again in September. So enjoy the beach. In the meantime, Ben.
So thank you all. You stole my line about the no meeting in August, but I will say that our work on the CON task force, among others, other activities will continue with this, among the staff and stakeholders. Commissioner Sargent and the team will meet on August 10th to consider issues related to the CON authority pertaining to home health and nursing homes and certain types of specialty hospitals. We will we'll have, I believe, a second meeting in early September before our next commission meeting in late September. So we would expect to update you on the progress of that task force. Recall that the first stage is, which is now complete, was to identify problems. We will gradually unfold through this fall month potential solutions, and rather than surprising all the four commissioners that were on that task force with some of the potential results, we'll be updating you in September and again in October on the progress. So when you get the final report, you won't be completely surprised by recommendations. So that's on that particular topic. On Certificate of Need, this will be a fairly busy month in September with probably 3 to 4 important CON decisions coming before you. There'll also be reports on the health provider breach assessment that we independently take on by reviewing the Office of Civil Rights at HHS reports on security breaches by Maryland providers and summarize that to you. It's broadly within our the scope of oversight of health information exchange in the state. We will also get some updates on the telehealth grants that are now underway and are ripe for reporting on their success. And lastly, as some of you know, early this spring we contracted with an organization like IHS, an organization called IHS Markit, which is responsible for conducting workforce studies for HRSA, the Health Services Resource Administration, and CMS. HRSA is responsible for managing the healthcare workforce and governing the safety net providers. IHS Markit has done workforce studies. We've asked them to look at the Maryland workforce, paying a special attention to primary care and behavioral health, but certain highly used specialists as well. As we move into the new total cost of care model, we are curious about whether that we have an adequate workforce, and we'll report that. They'll deliver that report to you in September. We've had a preliminary presentation of some of those results with stakeholders a couple of days ago, and there was a lot of interest. In some specialties, we do see significant deficits. In others, we see some supply levels that are greater than the country. So in general, it seems like there's areas to be optimistic, but we want to be cautious till we see the final results. That report will be given in September as well. And lastly, I should have noted this at the first, we always try to keep you abreast of our sister organization activities. And last week at the HSCRC meeting, Katie Wunderlich, a center director at HSCRC, was appointed by the commission to be the new executive director of HSCRC, subject to Governor Hogan's approval, which will we expect to come sometime later this summer, soon, maybe I should say. The commission's senior staff and others work closely with Katie and her team, so I wouldn't expect any change in our interactions with that commission. I also, on my final note today, and some of the new commissioners may not have noted this, but we do try to elevate our mid and junior level staff. Alana, Mariamu, Justine, Mahi, all get chances to give presentations, and I think they all did very fine jobs. And we really think it's important that that not only the senior staff but others are visible visible to the commissioners. And they want to note that because you wouldn't have known that they were less junior than people like me. So thank you very much.
Thank you very much. Before we depart, I'm going to make a confession. I made a big mistake today. The last time we got together, we have all new commissioners, but there's one commissioner I didn't have a chance to introduce, and that's Jason McCarthy. Jason, welcome aboard. Jason is the Vice President for Operations at the Kaiser Permanente Mid-Atlantic States. He's responsible for ensuring that Kaiser program promotes high-quality health care for members throughout Maryland and Virginia and D.C. And he's responsible for overseeing Kaiser's growth in the Baltimore service area. Is that correct? Yes. And prior to joining Kaiser, Jason served as district manager with CVS Pharmacy in Washington, D.C. He received his Doctor of Pharmacy from Howard University College of Pharmacy and his MBA from the University of Maryland in College Park. Welcome aboard. It's good to have you. you have any observations on your first meeting? Right, yeah. Behind the camera. Well, welcome aboard. It's great to have you. Thank you so much.
So anybody with complaints about payer data should take it to Jason.
Yeah,
I'm a lawyer.
I would think so. Clearly, these the mom and pop insurance companies in particular. Okay. All good things come to an end, right? So may I have a motion to adjourn? Second? Second, okay. All those in favor say aye. The ayes have it. All right. Have a great vacation and see you in September.